Hi, I'm Dr. Álvaro Ordóñez from Miami Implant Life and from the Picos Institute in Tampa Bay. The case that we're going to be demonstrating today is an immediate loading case post-extraction in a patient with radicular resorption, extensive resorption of the root. You can see it here in the scan images. And the whole idea was to minimize the surgical procedure and try to keep the grafting and incisions to the minimum. The implant that we chose for the performance of the procedure was the co-axis implant, the 12-degree implant, Trinex with a 4.3 platform, which allowed us to actually place the implant following the path of bond anchorage without having to actually compromise angulation, maximizing placement. During the convex CT imaging evaluation, we were actually able to isolate the roots and look at the distance between each root within the adjacent teeth, look at the extension of the lesion, and at the end the patient decided not to have orthodontic treatment done. He preferred to have the tooth extracted and implants being placed. The procedure that you can observe over here, it's called oblique slicing, and in the oblique slicing we can actually utilize these lines of the scan and put them in such a way that we can follow the actual axis of the tooth, and therefore we can obtain excellent images and excellent slices that are pertinent to the tooth itself. So you have total control on the way that you do your slice. We're doing the measurements from the crest to the floor of the nose, and we're also looking at the diameter of the ridge from the facial to the palatal aspect. And you can see over here that the ridge is not actually static. The actual geometry of the ridge is dynamic. We can see over here that we have a ridge with 8.2 millimeters. In the most coronal aspect and in the most apical aspect, we have 10.2 millimeters, a discrepancy of 2 millimeters, and a total length from the crestal bone to the floor of the nose of 22.8 millimeters. So basically, we are not limited at all in the length, and we are not really limited in the width of the implant that we can select. But what is creating a big limitation is the actual position of the crown, as we can observe over here, in relationship to the root and the available triangle of bone. If we actually look at the crown and we try to create an ideal placement site, we would have to actually perforate into the facial area to place an implant. So if we try to create the ideal placement following the protocols of Dr. Gans for the triangle of bone, we would have to actually create a big angulation in relationship to the existing area where that root used to be placed, the socket. So the whole idea was to select an implant that would allow us to do the placement without having to compromise too much either into getting into the performance of a major grafting procedure or having to angulate the implant too much, compromising the position of the implant within the bone. The co-axis implant is an excellent alternative, and you have two choices. You can utilize the 12-degree implant or you can utilize the 24-degree co-axis implant. So we started the atraumatic extraction process utilizing the pisotome. The pisotome is one of the piso devices available in the market for piso surgery, and they have an excellent system or an excellent distribution of tips for atraumatic extraction, very thin and long tips that can be utilized to penetrate the periodontal ligament. Most of the companies that have piezo devices in the market also have available tips for the same purpose, penetration through the periodontal ligament. And it's very important to actually penetrate at the angles. Wherever your facial table and your mesial table meet, exactly at the corner of each table is where you're going to be utilizing those tips for that penetration that I was mentioning. So any single one of the corners would be the ideal place for the position and for the activation. If you have to compromise, then you start by compromising on the lingual table, then on the distal table, then on the mesial table, and you always protect your facial table. So at this point, after you have been able to utilize the piezo tips, and you have to be very careful as you are getting deep because you're gonna be generating heat, and the irrigation is very limited as you get deeper. You don't want to cause necrosis of the bone because of overheating. So as you are penetrating, make sure that you apply very light pressure and that you allow the instrument to do the work. The tips that you're gonna see next are gonna be the PDL luxator kit, which are devices built specifically for atraumatic extraction and are distributed by Salvin Dental all over the world. They have different tips with different designs, and the important thing is that you're going to try to follow that initial preparation that was done by the piezo device, by the piezo tip. And the whole purpose is to actually create that luxation process, and the action of the forceps is specifically for removal. You're going to pick up the root and you're going to get it out without creating any type of forces, because we all know how delicate the facial table, specifically on a canine, is. You're going to be able to see over here the good aperture from the root canal done by the specialist, a little overfilled, but again, it was decided not to continue with the orthodontic treatment, and you can see part over here of the radicular resorption of the root, which was very big. We proceed to do the removal of any granulation tissue or any soft tissues in the area, and any infected tissue. It's very important to irrigate with saline solution as we are doing the curettage, and to take the appropriate measurements of the socket and their measurements from the most coronal part of the tissue all the way to the most coronal reference of the bone tables. At this point, we're doing the pilot perforation, and remember that we're trying to actually change the angulation from the angulation that the tooth had before, because if we just follow the angulation of the root, we would perforate and we would end up placing that implant on the facial area. So basically, we are doing the preparation for the implant side at an angle, following the sequence of burrs for the co-access system of the Southern Implant Company. This is the implant being taken out of the container into the latch driver, and we basically hope, when we're going to do this kind of loading, to get an excess of 45 newtons after placement. Observe the little dots for reference, so you can actually visually decide the actual position for the implant, because this is an implant in which placement becomes a sensitive decision process, because it's not a straight platform. It's a platform that is going to have an angle in which the most coronal part of that platform is going to have to be on the facial side, and the lower part of the angle is going to have to be on the lingual part. The implant is being taken into the preparation, the osteotomy site, and it's being placed. And again, at this point, we're trying to actually coordinate the dot of reference for the facial placement, so we can do the very precise placement for prosthetic purposes. At this point, we have a good positioning of the dots, but we have not reached the right depth, so we have to go a little bit deeper. But I just wanted to make sure that you will look at that. So this implant still being too coronal. These implants have a surface treated all the way to the top, so it's very important that we actually submerge the implant about a millimeter deeper into the bone. than we usually do. We don't want to flush the cover screw with the actual bone. We want to be deeper, a millimeter or millimeter and a half, to facilitate the platform switch process. So at this point, we're going by hand and with the ratchet adjusting the depth and actually adjusting the position of that implant, which we have achieved at this point. And I also would like you to pay attention to the actual discrepancy or the distance or the gap between the bone table, the palatal bone table, and the implant platform, the mesial table and the implant platform, the facial and the mesial. So basically, these gaps are going to be filled out with particulate bone. In this case, the selected graft material was Puros, which is distributed by Zimmer Dental, and we did a combination of Puros with platelet-derived growth factors by the OsteoHealth. It usually comes with beta tricalcium phosphate, but in this case we decided to mix it with Puros. So the next step is to utilize some components. We're utilizing the cylinder for temporary crowns and a screw. And it's important that you also have in your armamentarium an analog of this system, because the analog is going to facilitate the handling of the implant. And you need to actually calculate the interocclusal distance. So what we usually do in most systems is creating a little indentation or a mark with a burr. With this system, you don't need to do that because you have indentations prefabricated in the abutment, and all you have to do is count or mark the specific spot where you want to actually cut the abutment away for the interocclusal distance. So we proceed to remove it. We remount the abutment into the analog, and with a burr we proceed to actually trim it to obtain the right distance. This is a regular crown preparation burr, and this is a football burr to improve the actual dimensions of the abutment in reference to the occlusal clearance. You can see the flat, in this case, well positioned. And what we're doing now is that we're utilizing a burr to remove the apical part of the tooth. We're removing the root and we are leaving the crown intact, because we're going to utilize that crown for loading purposes. It's going to be the temporary crown, trying to maximize cosmetics and minimize changes in the appearance of the patient. So once the root is separated, we proceed to hollow that root utilizing a round burr, and it's very important to leave some layer of dentin surrounding the tooth, but especially in the facial part, so that dentin can serve as an opaquer, because remember that we're using a metallic temporary abutment. We proceed actually to open also a perforation between the incisal edge and the cingulum, because we need to have some access, because it's going to be a screw retain temporary restoration. We take it back into place and we index the abutment, and what's going to happen is that the acrylic is going to actually create retention, and it's going to create a connection between the abutment and the crown. We have to proceed to clean the excesses of acrylic, and in this case we had to utilize a burr. And it's important to use suction because you don't want the particles going into the surgical site. And once you have access, you proceed to remove the crown, which is now attached to the abutment. And in this case, I believe I was talking to my assistant and to other people watching the surgery, so I did not clean it on time. So it's important that you pay attention to it, because it's easier to be clean before you have the polymerization of the acrylics. So now what we're doing is actually mounting the temporary crown and abutment into an analog, and you can see the discrepancy between the finish line of the abutment and the actual crown of the patient. So we're going to have to do a reline procedure, and in that reline procedure we need to build what is called the emergence contour and the emergence of the crown. For this purpose we utilize a resin, try to select a resin that match the color, and try to create the best emergence profile for that crown, so you can actually transfer that to the soft tissues and maintain the soft tissue profile that you had in the original crown, minimizing changes in the perioprosthetic environment of the restoration. So at this point we're getting close to the final design that we want, and this design again is going to have an impact in the perioprosthetic environment. It's going to help us contour our soft tissues. It's going to help us maintain the anatomy, the papillas, the position of the margin, minimizing any kind of impact into the functional and cosmetic specific requirements to have a good restoration and good soft tissues and hard tissues. We're going to proceed now to put the cover screw in place, and the whole idea of putting the cover screw in place, and don't tighten the cover screw at this point, is to be able to guide our graft material, which is Puros and PDGF. Puros with PDGF. PDGF is from OsteoHealth. If you're using any kind of bioactive modifier like a PRF or PRGF or even PRP, you can go ahead and mix it with the Puros and utilize it. It will work very well. It will help you with the healing of the soft tissues. It will help you with the inflammation. It will help you to decrease pain. The patients usually don't complain about pain and inflammation when we utilize this type of procedures. We usually don't suture during this kind of procedures. There's really no necessity to suture the site, but you could use probably 6-0 or 7-0 polypropylene if you feel more comfortable with the approximation of the site, but there's no necessity. There are no changes whatsoever, and what we're doing at this point is trying to smooth the incisal edges of the adjacent teeth, and we're also checking the occlusion, trying to get the best occlusal setup as possible. We want to have a contact in closure, but we don't want contacts in eccentric. So basically one of the things that we do before we do the surgery is playing with the lateralities, trying to reorganize occlusion, going more into a premolar function, and trying to avoid canine contacts in lateralities and anterior posterior movements. This is the tooth, and you can see the excellent cosmetics that were achieved, because we didn't have to achieve any cosmetics. All we have to do was maintain the actual cosmetic appearance of the patient, maintain the position of the margin, maintain the actual interpapillary height. So it's a very interesting result. Look at the actual width of the attached gingiva, excellent biotype. We have an excellent length also. So it's the everyday case that you would like to do whenever you are in medial loading. 16mm implant was placed, 4.3 platform, excellent distance to the adjacent teeth. And remember that the most difficult part in this case was to be away from the facial table. So this is a post surgical scan, and what we can see over here is that we were able to maintain that facial table. We were able to get an excellent placement, excellent position, excellent parallelism, good anchorage on a canine, which is a tooth that is actually undergoing a lot of functioning, on a patient with TMJ disorders and parafunctional habits. So in this type of patients, you need to try to maximize anchorage. You can see the facial table over here. We were able to maintain, and this is a different view. And again, look at the tables being maintained. At the coronal level, we got an excellent facial table, which is going to be good for the long-term stability of the case and the perioprosthetic result that we are trying to achieve.